So what we're going to do today is we're going to take the cells, the matrix, that information that we've learned so far, and we're going to make our cartilage and bone grow. And in many ways, the growth that we see of our cartilage and bone are going to be very, very similar. And throughout the lesson today, we're going to talk about interstitial growth and appositional growth. And we're going to get into what each one of those mean, but those are going to be two terms that apply to the growth of cartilage as well as to the growth of bone. So we'll talk about each one of those. But for cartilage, and you can see here we have a 10-week fetus. 10-week fetus already has many of the foundational templates of cartilage laid down with which we are going to then convert into bone. For many of our long bones, we can even see here in the frontal part of our cranium, we've got some cartilage there as well as our maxilla and our mandible. But as we grow this cartilage, especially the structures where we're going to have cartilage throughout our adult life, that cartilage, remember, is going to become somewhat rigid, not completely hardened like we see in bone. And these cells are going to grow until they arrive at their final size. Now again, like we talked with bone and the epiphysial growth plate, that's going to be happening early to mid-20s. And after that time, the cartilage really doesn't grow. And the cells really are just maintaining their matrix. And so if there's an injury that happens to your cartilage, it's really not going to repair itself. We talked about the meniscus that often gets damaged when we have ligament injuries in our knees. Those just have to be cleaned, trimmed, removed because they're not going to regrow and they can't be replaced. So let's get to those two terms, interstitial and appositional. First, interstitial growth. Understand as we look at a section of cartilage, and this is going to be our Highland cartilage with its associated perichondrium. Interstitial growth, as the name implies, inter means what? Between, in between. And interstitial, stitial or stitium means stuff. So this is the growth between and within the cartilage itself. So this is going to be growth of our chondrocytes. So early in development, when we're growing our cartilage to form a template that's going to be transitioned into bone, our chondrocytes are going to divide inside their lacuna. And as they divide inside the lacuna, these chondrocytes are going to begin to act more like chondroblasts and produce matrix. And they're going to produce more and more and more cartilage matrix until they push themselves apart. And the two chondroblasts now are in their own lacuna. And so basically you've taken one chondrocyte, transitioned it into two chondroblasts, and once they've completely surrounded themselves again, now we have two separate chondrocytes in their own lacuna. It's like an adult somehow going back to a single cell stage, then dividing in half and becoming identical twins. Sort of what's happening here with this cartilage. Yeah. That's the next appositional growth. You just led right into that. Nice segue. So this is growth within the cartilage itself. And I think you can envision when we're taking our chondrocytes in their lacuna, which are three-dimensional structures, when we're making 2 cells or 4 cells, that's going to be in any dimension, three-dimensional growth. It's expansion of the cartilage. But when we talk about appositional growth, if we can envision the cartilage that looks like a long bone, this is going to be a thickening of the width, an enlargement of the diameter of the cartilage. And that appositional growth is going to be in that position that is the outermost layer of the cartilage itself, but it's also this first layer adjacent to the cartilage, that first layer of our perichondrium. Because remember, our perichondrium, much like our periosteum, has 2 layers. the outer fibrous layer and the inner what layer? Cellular layer. This is where we have our chondrogenic cells, our osteoblasts, like you talk about. And so that growth is going to be on the edge, and that appositional growth is going to widen the diameter of the cartilage. So we've got both the interstitial and the appositional happening at the same time. And so in our illustration here, we can see our perichondrium, our cellular perichondrium. We have one of those cells of the perichondrium close to the actual old cartilage, which is this light blue. And that progenitor cell is going to be transformed into an osteoblast that begins to put down a lot more new matrix. It surrounds itself with that matrix to become an osteocyte. Look how much thicker our new cartilage is. And now look what's happened to the perichondrium. It's pushed it further up. And again, this is happening all around the cartilage, so it's widening the diameter. It's enlarging the diameter of the cartilage. So interstitial means inside. And just remember, appositional, what's the opposite of inside? Outside, and that's going to be in our perichondrium. But both growth from within and growth from the outside are both going to account for the growth of our cartilage. And you can't have the normal growth of cartilage without both. So here's just our summary of the two. From the inside with our chondrocytes, from the outer edge of the cartilage and the perichondrium, appositional growth. This is three-dimensional, and this is more almost two-dimensional in the widening of the diameter. Now, bone. So when we talk about bone formation, and here we have a much older fetus, still looks a little bit like a Martian. You know, we may be approaching about 18 weeks of development at this part. This is 18 weeks from being a single cell, which to me, when you start having bones in 18 weeks and it looks that much like a person, that just blows my mind. How cells can diversify so rapidly. But this process of forming bone, ossification as it's called, or osteogenesis. I like osteogenesis more because we know osteo as a prefix means what? Bone. Genesis means what? The beginning or the formation of. So I like osteogenesis, but you'll hear ossification a lot as well. There are two ways in which our bones form. The flat bones in our body are going to form by what is referred to as intramembranous, and most of the other bones, especially our long bones, are going to occur via what is termed endochondral osteogenesis. So intramembranous. We talked about inter a while ago, interstitial, inter meaning between. What does intra mean? Inside. Inter is between, intra is within. So an interstate highway goes between states. Intrastate highway just goes around inside the state. So as the name implies, intramembranous, this means we're going to form bone inside of a membrane. We're going to get progenitor cells, they're going to be in the membrane, boom, they're going to start making bone. But the other type, endochondral, what does chondro mean? Cartilage. And the prefix endo means within. So in this case, endochondral ossification or osteogenesis is we're going to form a cartilage template first. And then we're going to slowly replace the cartilage tissue with bone. And so those are the two different ways in which we're going to form all the bones in the human body. Now, it would make sense, right, that you're going to have different ways to form bones? Because how many different shapes? We got 5 different shapes of bones, right? What are those shapes? Flat, short, long, irregular, and what's the fun one? Sesamoid. Reminds me of Sesame Street or Sesame Seed. Sesamoid. That's all 5. Very different looking, and so it would make sense that we would have different ways to form them. So let's take these two step by step. An intramembranous within the membrane. That membrane is going to be what we refer to as mesenchymal tissue. Now, y'all got that in lab, right? First class said y'all talked about mesenchyme. That's kind of a difficult conceptual idea for early histologists. If you don't really have an understanding or appreciation of human development or development in general, to think about this layer of tissue that can become any number of different types of cells. But that's mesenchyme. And within this layer of mesenchyme, that's going to lead to the production of a flat bone, our skull, maybe our collarbone. These cells are going to transition into osteogenic progenitors, osteoblasts. And we know osteoblasts begin to produce what? Bone matrix. And so they set up shop, they start making bone matrix, they start making other osteoblasts. They're dividing, producing more and more matrix, more and more, until we surround some of these cells with bone matrix, and now we've got osteocytes. Our progenitor cells and osteoblasts remain on the outside. Well, this growth continues to happen and happen and happen until we have something very reminiscent of our spongy bone and trabeculae, but these are a little bit thicker. And so rather than call it trabecular bone or spongy bone, it's referred to as woven. And this woven bone continues to grow and grow. Now we see blood vessels coming in. And so you see our osteocytes in portions of the woven nature of the bone, but the osteoblasts and progenitors get pushed to the outside. And at some point, this woven bone is going to be thick enough, these osteocytes are going to stop their interstitial growth so much, but our appositional growth on the outside is going to take off, and we're going to form two layers of compact bone surrounding this spongy woven bone layer on the inside. And so we're basically going to form one of the plates of our skull starting from scratch. Just by getting these stem cells in, and they start dividing and making more and more. Bless you. Until we have that flat plate of bone that's going to be a portion of our skull. And again, that's formed from our progenitor cells coming in and setting up shop in this mesenchymal membrane. So intramembranous. Intramembranous is fairly straightforward. Endochondral is a little bit trickier, but it's still fairly simple. Because the first thing we're going to do in embryonic development, as we saw in our pictures of our fetus, we're going to first form essentially a complete model of a skeleton in Highland cartilage. Have you ever seen some of these sculptors? They'll make a model of clay or sand, and then they will surround it with some metal that they poured and they forge, and then they will just remove the sand on the inside. Well, it's almost like what we're doing here. We're forming a model of cartilage first. We're going to use that as a template on which we're going to build our bone. Now, look, what kind of cartilage are we using? Highland cartilage. Now, don't let this freak you out, because a lot of times we think we're done growing when we're born. We're just going to get bigger. Check out endochondral ossification. Endochondral ossification, or osteogenesis, it doesn't happen and it doesn't complete until your epiphysial growth plates are replaced with bone. So technically speaking, endochondral osteogenesis can last for maybe up to 20, 25 years. So here's our Highland cartilage model. Let's say this is one of our long bones. As blood vessels come near to the cartilage template. Now, remember our cartilage cells are growing and dividing. How do cartilage cells receive their nutrients? What transport mechanism? You remember that from last week? Diffusion. Remember, cartilage is flexible, it's highly hydrated, so materials can diffuse in and out. Well, we get the blood vessels coming close as the cartilage gets bigger and bigger, but the blood vessels bring in osteogenic progenitor cells as well, these stem cells. And the stem cells set up shop, and they start to form a periosteum on the outside of the diaphysis, or the shaft. And as this periosteum forms, and we have our cellular layer of the periosteum, those osteoblasts are going to begin to produce a bone matrix that surrounds the middle of the diaphysis. Now, what's going to happen to diffusion when you put a collar of bone around the diaphysis? It's going to stop. Does stuff effectively diffuse through bone? No. How do osteocytes get their nutrients through bone? What are those processes? What are those little processes the cells send out? Starts with a C. Canaliculi. And they have to have those processes because diffusion can occur. So, when you wrap a bone collar around the diaphysis, you're going to strangle the chondrocytes, right? And the chondrocytes die in the middle. And when they die in the middle, blood vessels penetrate, bringing in more osteogenic progenitors, and the bone starts to replace the area where the cartilage died. That is going to be your primary ossification center. It happens in the middle of the diaphysis. And it's going to continue to lay down bone in an outward direction, as well as a lengthwise direction up and down the diaphysis of the long bone. So that's the beginning of laying down the bone. Certainly it's not the end all and the be all, because we've got these ends. What do we call the ends of our long bones? The epiphyses. And so we're growing, we're going along, we get ready to be born. Have we made all of this into bone yet? So around the time of birth, we're still making bone. We're still transitioning the cartilage to bone. And in our epiphysial centers, we had another process of cartilage dying, because now we've got bone forming around out here on the outside. We strangled the cartilage. It's died. We brought in more osteogenic progenitors into the ends of our epiphyses. Those are our secondary ossification centers. So do you see what's happening? The primary ossification center is moving up this way. The secondary ossification center is expanding in all the directions, certainly in this downward direction. We're squeezing the cartilage into one layer, one zone on either end. And that's our epiphysial growth plates. And again, this whole endochondral replacement of cartilage with bones happens until all of our cartilage is replaced, which again is going to be in your early to mid-20s. And it's at that point that the growth of the bone outpaces the growth of the cartilage, and the epiphysial growth plate gets completely replaced. And what you have is a remnant in your adult bones that are called the epiphysial lines. And you're done. You're not going to get any taller without surgical intervention. That's too painful to even talk about. All right? So, we want our skeleton to grow, our entire skeleton. You've got to have both. Intramembranous, within the mesenchymal membrane. Endochondral, within our Highland Cartilage template, as the bone outpaces and takes over the cartilage. You need to understand the difference in these. You need to understand which bones undergo which type of osteogenesis and the steps of each. I can promise you, you will see test questions about this. Have I lied to you yet? If I tell you it's going to be on the test, it's going to be on the test. Now, I want to focus a little bit now in a couple of slides. This is just sort of a synopsis of everything going on. Remember I said interstitial appositional happens in cartilage as well as in bone? So when we look at our growth all through embryonic development, fetal development, all through our adult life, we're looking at interstitial, appositional of cartilage, intramembranous, endochondral with bone. That's going to put them in place, and then the remodeling and the reshaping is going to happen with our interstitial and appositional. Again, just a reminder, interstitial within. And this interstitial growth, we can talk about our epiphysial growth plate, and we're going to on the next slide. But understand too, when osteoclasts remove bone matrix and they remove the osteocytes, when bone gets removed, you have to replace it. And so that removal, replacing, remodeling, that's going to be our interstitial growth inside the bone. If it's happening around the diameter, so again, our periosteum, the cellular layer of our periosteum, expanding the diameter, which may happen because of mechanical stresses, that's going to be our appositional type growth. So again, very similar to what we saw in cartilage, but also happening here in our bone. Now, let's talk about our epiphysial growth plate. You didn't get the detail of these layers in lab, right? Okay, y'all just talked about the growth plate. So what I want you to envision is that the epiphysial part of the bone is on top, the shaft and diaphysis is down below. All right, this little menu here is sort of in the way, but we're looking at an inset right there, that epiphysial center. So we can see differences in the histology of our cartilage in this particular section through our epiphysial growth plate. But this is going to be the area that looks most like cartilage because it in fact is. And this is your resting cartilage, or sometimes you'll hear it the reserve cartilage. This is cartilage that's just hanging around doing its job. It's, just cartilage, Highland cartilage. But really the business end of our epiphysial plate, and here's a concept I want you to think about. The epiphysial growth plate, the way you're lengthening the bones is by adding cartilage. The addition of cartilage, and that's going to be happening in our second zone, the addition of the cartilage pushes the epiphyses further apart. It adds material to the diaphysis. So cartilage lengthens the bone, and when it gets replaced with actual bone matrix, that locks that increase in place so that it can't just be changed. It can't go away. So cartilage lengthens the bone matrix, locks it permanently in place. So our cartilage begins to divide like crazy in this zone 2. You see how blue that is? That blue is going to be the cartilaginous matrix. These chondrocytes are going crazy. And they're going crazy because not only are they producing a lot of matrix, but they're dividing and producing a lot of cells. And they're dividing so fast that these chondrocytes look like stacks of pennies. They're extremely flattened. It's just a result of how rapidly they're dividing. That's adding tissue to our epiphysial growth center. We're not going to extend the diaphysis. We're not going to push. It's bone. It's not going anywhere. We're just thickening. We're thickening the epiphysial growth plate and moving the epiphysial growth plate upward. Have you ever seen people build a building like we got over here at the STEM Center? Or some people building these towers and supports in dams out of concrete? They will pour the concrete, and sometimes they have a sliding form. They'll pour it, slide the form up, pour some more, slide it up. That's what's happening with our cartilage in its transition to bone. Now, once we have all of these chondrocytes, then we get into this stage where the chondrocytes actually are going to hypertrophy. Now, what does hyper mean? Above. Hypertrophy means above growth, added activity. They're getting fat. And they're getting fat because they're resorbing a lot of the matrix around them. So you can see all the white spaces in these lacuna that you don't see with these stacks of pennies. These cells are getting much larger and much fatter. So, and you can see the actual purple color that's going to be that cartilage matrix is starting to go away. So we add the space with our proliferating stage. Now we're starting to remove the cartilage. And in these next 3 stages, we're transitioning it into bone. So we lay it down. We start removing the cartilage. Now in zone 4, this is where our cartilage cells themselves begin to secrete and produce a calcified type matrix. Now this is not your hydroxyapatite that bone produces, but it is a calcium-rich matrix, and that's going to shut down diffusion. What do cartilage cells have to be able to do? Diffusion of materials. And if they can't diffuse because you're laying down this calcified matrix, the cartilage cells die. Now, think back to our primary ossification center in the shaft, the diaphysis. Those cartilage cells died because we wrapped that bone collar around it. When they died, that opened up a space for bone cells to come in and start laying down bone matrix. Well, the same thing is happening. When the cells die in zone 4, well, in zone 5, right behind them, there's our osteoblasts coming in, laying down bone. And what's going to happen, this whole field is going to slowly move upward. So we're putting down bone here. Well, as we're producing more cells on this end, our reserve cartilage is growing on this end. These zones are just going to keep sliding up like an elevator or like that form for pouring concrete to make this tower, and that lengthens the bones. And remember, we're doing it in both directions because we have 2 epiphysial growth plates. If cartilage is able to divide like that, why can't it be repaired? Because understand, this cartilage is still under the control of sort of our embryonic fetal osteogenesis. And we're going to see, once we get past that stage, then the cartilage cells just stop and they're just maintaining. They don't really ever, are they able to revert back to that interstitial growth where they can go from a chondrocyte to a blast to a site. Once you get past 25, that's it. They're locked in. That's a good question. We're going to see that regulation of this, and bone especially, I mean, it's under a lot of hormonal control. And certainly the sex hormones, when you go through puberty, that's a big one. That's going to make this thing go crazy. Your parents ever said, I think you grew an inch overnight? And your parents ever said that? I mean, that's hormone regulated. So interstitial growth, much like we saw there, a reminder, appositional. We can see the increase in diameter. And where appositional growth largely happens is in our periosteum, just like we saw that appositional growth happening in our cartilage with the perichondrium. So osteoblasts producing thicker layers of bone from the outside. And we can also thicken this bone by our osteoclasts on the inside not being as active. If our osteoclasts are not being as active and our osteoblasts are outpacing them, we're going to deposit more bone than we lose. That's going to help the bone get thicker. You see how it's a balancing act between bone resorption and bone deposition? And that's continually happening. Now, speaking of bone deposition, bone resorption, osteoblasts versus osteoclasts, it seems like a tug of war. And it really is, but they're both working together because we're going to have mechanical stresses on our bones, on our body, continually through our life. But like we mentioned with puberty, our bones are also going to be influenced by the various hormones that are coursing through our bloodstream and are secreted. And when these things happen, our bones are going to respond. For instance, when we have a lot of mechanical stress on our bones, and we may think, well, they're rock solid hard. You can stress a rock, but if it doesn't break, it's not, what's the big deal? But with our bones, the stresses we put on it are the skeletal muscles that are pulling on the bones. The bone's going to feel and sense, because remember, bone is living tissue. But not only that, but the gravitational forces that are pushing down. So our chondrocytes locked in their lacuna, remember, they're fluid-filled, and that fluid can be compressed, and so those compressional forces are going to cause our bone cells to respond. And in fact, our osteocytes detect that stress, and they're going to send signals to our osteoblasts. They're going to say, hey, osteoblasts, we're getting stressed in this area. Why don't you put down more bone matrix, and let's make the bone stronger. Because this person, they're going to keep doing this. They've done it day after day. We might as well get ready. I don't think they're going to change their mind. Now, here's the opposite. If you are not stressing your bones, if you're not putting stress on your bones, remember, bone is living tissue, living cells. What do cells need to survive? Glucose, ATP, oxygen, right? It takes a lot of work to keep cells alive. Your body is lazy. Don't look at the guys, okay? No, our bodies are lazy in the sense that our bodies are built to conserve energy. And if you're not using it, then why are you paying for it? And so your body says, look, we're not stressing our bones, so you know what? We're going to get rid of the bone. Osteoclasts are going to take the bone out. They're going to take the osteocytes out. We're not going to keep paying them. They're not doing any good. And you can clearly see that happen with our astronauts. Not only does weightlessness in space cause your muscles to atrophy when you don't use them, and many of you are going to see this in your geriatric patients if you're working in those clinics, if you're working in nursing homes and you have bedridden patients, their muscles are going to atrophy. But not only does that happen to astronauts, their bone density decreases because they're not stressing the bones, because they're not subjected to gravity. Now, most of my life, I wanted to be an astronaut until I saw this slide. For every 16-hour day, do you see how much exercise they have to do? 4 hours out of a 16-hour day, every day. I'm out. I'm sorry. I'll just wait until I can pay to take a ride. That's all I really want to do. Take a ride, go up and eat some astronaut ice cream, and then come back. That's all. Exercise, I'm not paying for that. But that gets at the point that if you don't use it, your body's not going to maintain it. And again, many of you in those situations where you're dealing with elderly, that's going to be a big concern for those individuals. So that's mechanical stress. Hormones, like we see when we go through puberty, they're going to play a tremendous role in the growth and the development of your bones. Now, are we good with hormones and how hormones work? Hormones are chemical signalers. They can be sent possibly from local cells, or they can be sent from distant targets. We're going to look at a couple of hormones in the next slide that are produced by or near the thyroid gland in your throat, and that affects growth over your entire body. But for those hormones to be interpreted, these target cells have to have the receptors for those hormones. Before insulin is going to allow your cells to take up glucose and lower your blood glucose level, what type of receptor do those cells have to have? An insulin receptor. Do you see? It's like if you have a phone, which most of you do, you can't have a conversation if somebody else doesn't have a phone to hear you. So it's a two-way conversation. And so as I mentioned, insulin with glucose and blood sugar, There was another hormone that was also used to affect blood sugar. What was that hormone? Glucagon. Insulin lowered blood sugar. Glucagon raised blood sugar. Well, guess what? We have two hormones that essentially work in a very similar way to affect calcium blood levels. Because as you go through the rest of 238 and you move into 239, you're going to see calcium does everything. It's required for everything. So having a certain blood calcium level is important. And so when your blood calcium is too high, your thyroid gland is going to produce a hormone called calcitonin. Now, these cells in your thyroid are called parafollicular cells because they're around the follicles of the thyroid. But I would rather you just refer to them as C cells. They're called C cells because they produce calcitonin. Because if you think, okay, calcitonin is produced by parafollicular cells, you're going to get really, really confused because parathyroid hormone is produced by cells where? Not in the parafolliculars, but in the parathyroid glands. Do you know your thyroid gland? I don't think you get endocrine in 239. Your thyroid gland is this butterfly-looking gland that sort of surrounds your larynx. Your parathyroid glands are two little knobs of glandular tissue on the side, on each side of your thyroid gland. So it's completely separate tissue. But in that proximity, it's interesting because each thyroid gland and the parathyroid gland produce hormones that regulate calcium. Calcitonin lowers blood calcium. Parathyroid hormone, which is also called parathormone, it increases blood calcium. Now, one of the ways that we increase it is by affecting bone deposition. If we deposit more calcium in the bone, certainly that's going to lower our blood calcium, right? If our intestines are signaled, hey, don't take up any more calcium, we have enough. Okay, just pass it out in your feces. And your kidneys say, you know what, we got too much in the blood, let's put some of this in our urine. That's a way to eliminate the excess calcium from the blood. And if you learn sort of the steps of how you reduce calcium, guess what you're going to learn for parathyroid hormone? The opposite. If you need more calcium in the blood, well, let's get our osteoclasts working overtime. Let's dissolve some of that bone, put calcium into the blood. We need more calcium? Hey, small intestine, let's get busy taking it up from our diet, from what we've eaten. So, instead of putting calcium in our urine, we're going to tell our kidneys, hey, let's keep the calcium. Let's put less in the urine. And in that way, keep our blood calcium up. So, let's look at some of these hormones. We've already talked about calcitonin and parathyroid hormone and what they do relative to osteoclast activity. So if we need more calcium, parathyroid hormone is going to cause our osteoclast to dissolve it, release it into bone. Calcitonin is going to tell the osteoclast, hey, take the day off. Don't release any more calcium. We need it to stay in the bone. But growth hormone, this is what's going on during your fetal embryonic development. That's going to cause your osteoblasts to really kick into high gear. During your childhood. But then when you get to puberty and the sex hormones kick in, that's when your epiphysial plates are going to just go nuclear and just totally go wild. But again, once we get in our adult size and shape, it's as if the cells just go off the grid and they can no longer revert, go back, and do that interstitial growth that we see during these early periods when we're under the control of these hormones. Now, more and more evidence is showing that there are certain factors that can cause cells to do that, but it's not normal for that to happen. All right, I don't want to hear any snickering. I don't want to hear any comments about old people as we go through this. I'm very sensitive to this. But as people age, and again, for those of you that are going to be in nursing home settings, you've got to understand, and I think most of us are aware, that the elderly have very brittle bones. I mean, elderly stumble, elderly fall all the time, and it's very easy for them to break bones. And it's very dangerous when that happens. But the brittle bones happen because there's not as much collagen being replaced by the osteoblasts in this whole restructuring process. And without collagen to give the flexibility, the bones become brittle. It's like taking the rebar out of the concrete. But not only that, but we're losing a lot of the hydroxyapatite. And so the bones are thinner and weaker by nature because we don't have as much of the concrete, so we result in this thing called osteopenia. This is like a bone density table. But after you get past 40 and you start moving on, you're losing activity of osteoblasts. And unfortunately, ladies, as you get past 40 into your 50s and 60s, your osteoclast activity is going to tremendously outpace your osteoblast, so you dissolve more bone than you deposit. And that's largely because of the change in the hormones that's happening at menopause, especially the estrogens. And in that case, you end up with osteoporosis. This is our normal spongy bone trabeculae. This is osteoporotic. You see how it got its name? Look at all those pores. And you can recognize an individual with osteoporosis, can't you? Have you ever seen the little lady stooped over with the hunched back? That's a very characteristic look for someone that's got severe osteoporosis. Now, you can take your calcium supplements. You can try the hormone supplements. That's going to head some of this off. But until we come up with a better way to increase the activity of osteoblasts and decrease the activity of osteoclasts, this is going to remain a problem. And when you do hormone replacement, you've got to be careful, because while you're trying to head off osteoporosis, what are you increasing your risk for? Breast cancer. So it's a double-edged sword, and I don't think anyone's got the perfect answer for it yet. But the last thing I want to leave you with, most of you in a health setting are going to encounter broken bones. And what happens in the process of a broken bone and healing, well, much like any injury you have in your body, you're going to have a blood clot. You're going to have bleeding that takes place and fills the broken area. And it's going to be principally going to be within that periosteum. And within that layer, you're going to see blood vessels start to degenerate within the clot. And we're going to remodel that blood clot into a fibrous, cartilaginous callus. And they're trying to illustrate we've got Highland cartilage being produced here. You know, in endochondral osteogenesis, you had cartilage first and then bone. That's what we're doing here to repair this long bone. These progenitor cells came in through your blood vessels, through your bloodstream. After we lay down our cartilage, which takes about 3 or 4 weeks, now our osteoblasts, osteogenic precursors come in. We start to replace the cartilage with bone. You see it's kind of a woven bone, much like an intramembranous. It's going to be lightweight. We're healing the gaps. And that's going to take 3 to 4 months. You know, they tell you you're going to be in a cast 6 to 8 weeks. When you get the cast off, you're not done. You don't want to be doing crazy stuff when your bone's like this. And over time, that woven bone is going to be remodeled into what basically looks like a normal bone. But if you look at the periosteum on the outside and that compact bone, it's always going to be thicker where you broke it. Because I guess your cells are like, you know, if we were stressed so much that we broke, we want to make sure when the idiot does it again, we're better prepared for it not to break.